PowerPoint.
First, keep your slides open on the desktop and then start share.
Then start share. Yes, fine. Make it full slide.
Full
Yeah, make it full screen.
Slideshow, na?
Yeah, slideshow. Bus, start.
Yes, you
Chal,
can.
Good
all the
afternoon,
best.
everyone. Good morning, sir. Good morning, ma'am. Today, we are going to discuss a very important topic in neonatology, which is newborn born to a mother with autoimmune conditions. So, our three main objective for today will be to understand the transplacental antibody effects, to recognize the neonatal presentations, and to develop a structural clinical approach. Our approach will be to review the maternal history, to identify the antibody, examine the neonate, targeted test, and the management. So the four key maternal autoimmune diseases which we are going to cover are Graves' disease, LO and autoimmune thrombocytopenia, myasthenia gravis, anti-Ro and anti-La antibodies in SLE or Sjogren's. So the first case which I am going to discuss today is maternal grave disease and its presentation of fetal thyroid goiter. So as we know, it's found in 1 in 500 pregnant women. So basically, an autoimmune disorder in which immunoglobulin they bind to the TSH receptors in the gland, and they increase the production of T3 and T4, and it causes the thyrotoxicosis. The mothers can be treated by some anti-thyroid medication like propylthiouracil and methimazole, or they can opt for radioiodine therapy and the surgical removal of the gland. So the three presentations of fetal thyroid goiter in this case I will be discussing. So it's found in 1 in 5,000 births in maternal Graves' disease. The less common cause can be dysharmoniogenesis due to genes involved in the pathway of thyroid production. So as we can see in this flowchart, there are three key mechanisms. First of all, in maternal Graves' disease, there are two types of antibodies which are transmitted transpresently. First is TSH stimulatory antibodies which cross the placenta, and it can increase the T3, T4 secretion, and it can cause a hyperthyroid goiter. Second is the thyroid inhibitory immunoglobulin. So my screen is visible.
Yes, your screen is visible and you're clearly audible.
Something is happening. I'm not able to see my slides.
You can stop sharing and then share again.
Okay.
Or share. Just put it in slideshow mode.
So we were discussing about the three types of mechanism involved in the fetal thyroid goiter. So the first is we already discussed, it's thyroid stimulatory immunoglobulin, and the second is thyroid inhibitory immunoglobulin. It can cause fetal hypothyroid goiter. And the third is the transplacentally derived anti-thyroid drugs which mothers are receiving. It can cause fetal hypothyroidism goiter. So what are the effects on fetus? As we can see in this flowchart, this ultrasound image of prenatal ultrasound, which is showing the anterior cervical echogenic mass of variable size. From this diagram, we can say it can be hyper or hypothyroidism. We can distinguish by putting a Doppler. If the vascularity is increased and there is increased bone age, it is hyperthyroidism goiter. And if there is maintained if the vascularity is maintained and the bone age is also less on baby's IUGR, it can be a hypothyroid goiter. So the in fetal goiter, there can be nuchal hyperextension, which can cause dystocia, and there can be for need for the cesarean delivery. Further, it can cause a tracheal compression, and there can be difficulty in fetal swallowing of the amniotic fluid, which can cause the polyhydramnios, premature delivery, and can cause the airway obstruction and increase the mortality and morbidity. So the antenatal management is divided into two parts, fetal hypothyroid goiter and fetal hyperthyroid goiter. So in fetal hypothyroid goiter, generally we reduce or discontinue the maternal antithyroid medication. Secondly, what we can do, we can inject intraamniotic injection of levothyroxine every 1 to 2 weeks until the delivery. Subsequent injection is depending upon the re-enlargement of the glands on the further prenatal screenings. In fetal hyperthyroid goiter, first line management is to administer the or increase the dose of antithyroid drugs to the mother, and occasionally we can also increase the dose of the antithyroid drugs, which can be sufficient to maintain the thyroid levels of the fetus. But subsequently, it can cause hypothyroidism in the mother, so we can always supplement the mother with levothyroxine. If there no effects are seen, we can anyway do the chordosynthesis or amniocentesis to look for the exact values of the thyroid function test. So, mothers who are treated with the anti-thyroid drugs, there can be two presentation. If their drugs are too much, it can cause hypothyroid goiter, in which we have to decrease the drug or stop the drug, or can give intraamniotic levothyroxine injection. And if there is not enough drug, it can cause hyperthyroid goiter. In this case, we can increase the dose of the drug or simultaneously supplement the mother with the levothyroxine. So the postnatal management of newborn is all newborn should be screened for thyroid dysfunction within 2 to 4 days after birth. So in which we screen TSH, free T3, free T4, and TSH receptor antibody. There can be two possibility. There can be a normal test with positive thyroid receptor antibodies, in which we have to weekly clinical weekly clinical plus lab follow up until the thyroid receptor antibody tests are negative. Second, we can have thyroid dysfunction with antibody screening positive or negative. So depending upon the thyroid function, hypothyroid will be treated by levothyroxine and hyperthyroid will be treated by tablet methimazole and propranolol. The next case which I am going to discuss today is maternal immune thrombocytopenia and its presentation, very fetal presentation of fetal brain hemorrhage. So there are two types of maternal immune thrombocytopenia, autoimmune and alloimmune. Autoimmune is found in 1 in 500 pregnancies, and in alloimmune, it is 1 in 2000. So, platelet or antigens in autoimmune is maternal origin, and in alloimmune, it is of paternal origin. In autoimmune, the maternal platelet count will be low, and in alloimmune, it will be normal. So, complication, the fatal complication of fetal brain hemorrhage, it will 1% in autoimmune, and in alloimmune, it is 20%. Recurrence is not reported in autoimmune, but alloimmune, it is 50 to 100%. The management is more or less same. It's immunoglobulins and steroid. So basically, these maternal anti-platelet antibodies, it crosses the placenta and it causes fetal thrombocytopenia. In 1% cause, it can cause fetal intracranial hemorrhage. In alloimmune, the risk of fetal intracranial hemorrhage is 20%, and the further recurrence is 100% if the father is homozygous for this platelet antigen, and 50% if it is heterozygous. So both alloimmune and autoimmune, it causes the transient neonatal thrombocytopenia, and it can present with clinical symptoms of petechiae, ecchymosis, or melena. So overall, the fetal intracranial hemorrhage, the most common cause is prematurity. Other causes can be trauma, alloimmune thrombocytopenia, or maternal ingestion of any drugs like warfarin. So prenatal diagnosis we can do by doing the ultrasound, in which we can see the clots within the lateral ventricles. And sometimes if the hemorrhage is too much, it can cause a ventriculomegaly due to the obstruction of aqueduct of Sylvius. In severe cases, these intracerebral hemorrhage, they can form the pores and it can cause the porencephaly. And sometimes these fetus can become severely anemic and can develop hydrops. So the postnatal management is depicted in this flowchart. I will discuss in detail. So the baby born with mother with history of acute or chronic ITP, these all newborns we should have do cord platelet count if possible. If not, we can do the peripheral blood smell as soon as after birth. If the baby can have presentation of fatigue, bruises, or any signs of bleeding. So after the report of platelet, it can be divided into two scenarios. If the platelet count is more than 1.5 lakhs, there is no further monitoring is required. and repeat examination after 1 week is advised. If the platelet count is abnormal, is divided into further two categories. If it is less than 50,000, baby should be admitted to NICU and ultrasound cranium to be done. And further, the less than 50,000 can be divided into two parts, 30 to 50,000. And the baby is asymptomatic, we have to give the IVIG. And if the baby is symptomatic, we can give IVIG plus platelet transfusion. In the last, if the platelet count is less than 30,000, or if the baby is symptomatic, we can always give the platelet transfusion first, followed by the IVIG. So there is only one scenario. If the baby is less than 30,000, although he is asymptomatic, we have to give the platelet transfusion first, followed by the IVIG. If the platelet count is between 50,000 to 1.5 lakhs, daily monitoring of platelet count is required until the nadir of 2 to 5 days. Third is the maternal myasthenia gravis and its two presentation of transient neonatal myasthenia gravis and the fetal arthrogryposis multiplex congenital. So basically, it is found in 1 in 30,000 of pregnant women. Autoantibodies are directed against the acetylcholine receptors. In the diagram, we can easily see the acetylcholine receptors. They are released at the neuromuscular junction after the nerve impulse, and they bind the muscle and they cause the contraction. So clinical features can be mother can have the painless, fluctuating painless muscle weakness with waxing and weaning type of pattern. They can be treated by some drugs like pyridostigmine, prednisolone, plasmapheresis, and IVIG. So what pyridostigmine does, it inhibit the acetylcholine esterase enzyme, and prednisolone and plasmapheresis, they can all decrease the production of antibodies. The last treatment, what we can do is surgical involvement, which is the excision of the thymus gland, which is enlarged in the myasthenia gravis. So the effect of maternal antibodies on the fetus during the pregnancy. So there are the two types of receptors, fetal receptors and the adult receptors. If the acetylcholine receptor antibodies, there are 2% chances the antibodies they appear before the 32 weeks of gestation, what we call it as fetal receptors. So in that case, the presentation will be arthrogryposis multiplex congenital. If they are adult type of receptors, in more than 33 weeks of presentation, the presentation will be the neonatal myasthenia gravis. So the transient neonatal myasthenia gravis, it is due, we already discussed, it is due to passage of transplacental maternal antibodies. It temporarily affect the baby's neuromuscular junction. These usually appear within 24 to 72 hours. The clinical presentation, it will be poor feeding, weak suck, weak cry, facial weakness, hypotonia, or respiratory distress. It occurs in 10 to 20% of babies with affected mother. It's a temporary condition and it usually resolves in 2 to 4 weeks. Severity doesn't correlate well with the mother's disease severity. So mainly management is the supportive care. Further, we can support with the feeding support like orogastric feeds, respiratory support if required. And if the drugs are required, neostigmine is the drug which we gave in the acute to relieve the acute symptoms of the baby. Further, if the refractory cases, we can do plasmapheresis and the IVIG. The last one is anti-Rho and anti-La antibodies, which can found in few autoimmune disorders like the Sjogren's syndrome, SLE, rheumatoid arthritis, and undifferentiated autoimmune disease. It's found in 1 in 100 pregnancy. The antibodies, it usually crosses the placenta and it causes apoptosis, inflammation, and fibrosis. And it causes the imbalance of calcium homeostasis, which can further increase the levels of interferons. And the presentation can be cutaneous, hematological, hepatobiliary. In cardiac, we can have fetal heart blocks. And it usually starts at the 16 to 34 weeks of gestation. The risk of fetal heart block varies between 0.2 to 2%, and it depends on the levels of anti-Rho antibodies. So basically, if the mother is positive for anti-Rho and anti-La antibodies, we have to offer a prenatal counseling and the prenatal counseling followed by the prenatal some drugs which we have to ask the mother to take, and further serial ultrasound to rule out the fetal heart blocks. So neonatal lupus is an entirely distinct entity from the SLE, as we discussed, it's due to the transplacental transfer of the autoantibodies. Mostly it is anti-Rho 78% and anti-La is 5 to 10%. Manifestation can be cutaneous, uh, thrombocytopenia, neutropenia, or hepatobiliary. The typical they have the rashes over the scalp and the forehead, which occurs after the exposure of UV light and at around the 6 weeks of age, and it heals by the 3 to 4 months of age without scarring. So this is the management plan which I have taken from the Journal of Fetal and Neonatal Medicine. So basically, what they have did, they have given all pregnant women, like 10,000 pregnant women, hydroxychloroquine. This is the main drug to prevent the CHVs in the mother in the fetus. So how HCQ works? HCQ is an anti-malarial drug. It has a cardioprotective effect and it inhibits the toll-like receptor signaling. So what they have found ki they have given 10,000 pregnancies mein they have given to HCQ, and in only 2% case, like 200 cases, they have the degrees of heart block. So first degree of heart block, second degree, and third degree. First degree heart block, they didn't do anything. They just monitor the baby and to prevent the further progression of first degree to second degree and third degree. In second degree and third degree, they have tried dexamethasone, steroid, plasmapheresis, and immunoglobulins, but there are not much studies and the results are inconclusive. Further, they need lifelong pacemaker and cardiac support. So as we discussed, the most dreadful feature in this case is congenital heart block, which is permanent and it requires the cardiac pacing. Cardiomyopathy is a rare but a serious sequelae. Chances of recurrence in the subsequent pregnancy is 20%. An at-risk pregnancy should undergo a non-invasive fetal echocardiography regularly as per the guidelines, which indicates if we have diagnosed the baby has CHVs, we have to screen it every 2 to 4 weekly to diagnose further progression of first degree to second degree and third degree heart blocks. So these are the references which I have taken and have prepared these slides. So
Thank you, Dr. Aarti, for very detailed and interesting presentation. Now I would request our chairpersons to share their experience if they have dealt with such cases, and that would be interesting too.
Poonam ma'am, you start then.
Hi, Ankur Swati. Very nice presentation, Aarti. I think there were a lot of things to be discussed, but very well done algorithm, and so that's nice. So we recently had a baby, recently meaning 2 years back, who had this baby girl was IUGR, and she had a lot of skin scarring. And mother did not give any history. So a baby was doing well. We took derma, this thing. They were not interested in any investigations. But eventually mother came out to be positive for SLE. So, that was interesting. Sometime it may be the other way around. But I think all these conditions put together, there is a significant load. We all need to be aware of the presentations and investigate and do things accordingly. So that was something which happened recently. This baby had a lot of, we thought, some chicken pox or something, but she did not give any history. She had no problem whatsoever, and she was diagnosed after she had delivered this baby. So that was interesting.
yeah, ma'am, exactly. Actually, it's not like if mother is positive for anti-Rho and anti-La antibody, it's not necessary she is symptomatic. She can be asymptomatic also. So it depends on the levels of the antibody. If the antibody level is less than 50 IU per ml, they have no risk in fetus.
So yeah, again, like, whether you're looking at the baby or the mother, like you have to be open to the possibilities.
Yes.
Like what all could be there. So in this case, the mother presented later.
Okay, thank you, Aarti. Am I audible?
Yes,
Yes, sir.
So very well presented, very crisp, though even though it was not comprehensive, but it was very crisp and related to our motto of daily pits. So I think most of us do encounter autoimmune disease in pregnancy, very common. And out of all these pregnancies, if you look at the prevalence, the antiphospholipid syndromes and ITPs are very, very common. And the rare disorder which you have already discussed, like the Graves' disease, the anti-Ro, anti-La positive, the other maybe arthritis or something like that. So it's not that they would present like a severe fetal and neonatal complications. The common problem during the fetal and neonatal pregnancies, problem would be like there are chances of abortions are very high in certain diseases like antiphospholipid lipid syndromes with SLEs. But they can also present with fetal growth restrictions, sometimes because of premature delivery. They can have problems like of premature related complications and the IGR related complications. So as a clinician, we should also know that are the common thing. For that, you need a multidisciplinary team, including the role of the obstetricians and the gynecologist. And out of all these, most of them, you need a frequent and close monitoring and follow-up. So recently we have cases of ITP and NAIT, and also one cases of Graves' disease, and they ultimately turn out to be a normal kids in due course of time. If you look at the one of the, what you have discussed about the grave complications of anti-Ro, anti-L. So the one of the landmark trial, which was known as a patch trial. Patch means preventive actions against congenital heart block. And they found that if you give chloroquine, hydrochloroquine to the pregnant ladies before 10th week of pregnancy, and they can prevent the recurrence rate of congenital heart block in the range of less than 50% from the baseline rate. So nowadays it is the, standard mode of treatment for managing both SLE and as well as if the mom is positive for anti-Ro, anti-La, and specifically if it is the previous kid is already affected to congenital heart block. And we do have other treatments available for other diseases, like you have already discussed about the propyl thiouracil for the Graves' disease. We do have prednisolone and the immunoglobulin for various other disorders like ITP. So I think you have, really evaluated, what should be the approach of pediatricians or neonatologists while counseling the parents. These all are things important, and you presented it very well. Thank you, Dr. Puna. I think you have given your right input for this specific presentations. Thank you.
Thank you. So if a mother is already diagnosed with SLE, and if the disease is well controlled, does this affect the chances of neonate being affected during the
See,
time?
so skin problems are not uncommon. So they can have mild to moderate thrombocytopenia. For that, you don't need to admit the patients, because if they are born with a fair maturity, maybe a mature baby, then you can monitor the patients on. They would take time to resolve. Platelet takes time to resolve. So I think most of them can be managed at home only on frequent OPD follow-up. And obviously, if they have certain complications in case of related to severe, generally what we have seen, apart from NAIT, most of the thrombocytopenia related patients can be managed anything. We do follow certain protocol that we give transfusion to less than 20,000, but certainly we have seen that it doesn't cause any hemorrhage to the patient if they are hemodynamically or there are no complications to the baby.
Basically, you just have to wait for the antibody titers to drop, and it kind of takes care of itself. So that of that time, that's what would happen.
Yes, ma'am.
I think we
So
also.
South Asian means there's 70% chances of the cutaneous manifestation in SLE 70%.
And what about
Yeah,
heart block, more serious complications which are going to last? If the mother's disease is well controlled, does this reduce the chances of having a heart block in the newborn?
Ma'am, basically, there is role of HCQ. If the mother is positive for anti-Ro, anti-La antibodies, if we are giving HCQ, it decreases the risk to 98.7%. It's mentioned in most of the studies. So anyway,
Not
we can all
98.7. You have to look at the baseline data. Baseline, it is the primary pregnancy, the chance is 2%. If the recurrence is, as you told, that it's 20%, maybe 6 to 10 folds higher. So obviously from the baseline, it will decrease to less than 50%. There are only one or two randomized controlled trial. We have to look for, however, the systematic reviews and meta-analysis are in favor of giving early hydroxychloroquine. Early means, we want to give before 10 weeks, because between 16 to 24 weeks, they would certainly
yes.
cross and they can cause damage to the heart block bundles.
think we also have our pediatric endocrinologist, Dr. Swati Kanodia. Dr. Swati, are you there? Dr. Swati Kanodia?
I think she left.
There, but yeah. So yeah, I see you don't see any questions in the chat box. If the audience have any questions, they can unmute themselves and ask. Otherwise, shall we conclude, Dr. Ankur?
Yeah, we can conclude. I think
Thank you,
it was
Dr.
short and crisp, so
Very short and crisp and informative presentation. Thank you, Dr. Aarti, and
Thank you, ma'am.
to our learned chairpersons for sharing their valuable time and expertise. And next month, we will be back with another interesting topic. Till then, good afternoon to everyone.
good afternoon. Thank you, all of you.
Thank
Thank you,
you.
ma'am.
Thank
Thank
you.
you, sir.